All right, so this is going to be pulmonary vascular disease. Really, this is going to be pulmonary hypertension. All right, so we're going to review pulmonary hypertension here. We're also going to review the differential diagnosis, the causes of pulmonary hypertension, how to pursue the diagnosis, what the next diagnostic steps, as well as treatment for all the different types of pulmonary hypertension. All right, so do this question here. So let's kind of go into pulmonary hypertension a little bit. So what is it? So the pathophysiology here of all types of pulmonary hypertension, one is going to start with pulmonary endothelial injury or vasoconstriction, all right? Now, usually, especially with a type 2 pulmonary hypertension secondary to heart failure, or type 3 pulmonary hypertension secondary to hypoxia, initially it's going to be reversible just to increase pressure in the pulmonary. But unfortunately, the pulmonary arterioles respond to this increased hypertension in any way, shape, or form by one, undergoing intimal fibrosis, you may see here, so gets hardening of the endothelium of the arteries, and two, big thing is that they end up getting medial hypertrophy as well. This decreases your pulmonary arterial area, which increases your PA pressures, and at the end of the day, you have irreversible decreased pulmonary arterial area, increasing your mean PA pressure. All right, so that mean PA pressure for pulmonary hypertension used to be 25, but now they've shown that a mean pulmonary artery pressure, greater than 20, increases the risk of mortality. So this is our new diagnosis of pulmonary hypertension, would be that mean pulmonary artery pressure greater than 20. So the question is, what type of things end up increasing and causing pulmonary hypertension? All right, so maybe to touch on this question gets to one of the most common causes. So by and large, 90% of all causes of pulmonary hypertension are going to be either due to type 2 or type 3. So which ones are these? So type 2 is going to be an increased pulmonary capillary wedge pressure, right? So type 2 is going to be right here. So why are these patients getting increased pulmonary capillary wedge pressure, which is a stand-in for your left atrial pressure? And there's different ways, right? So they can get mitral regurgitation, they can get mitral stenosis that can increase pressure in their left atrium, subsequently their wedge pressure. Subsequently, that pressure can go back and cause increased pulmonary capillary wedge pressure. Most commonly, it's going to be heart failure with reduced EF or a very stiff heart and heart failure with preserved EF. So all those things can increase your left atrial pressure when you do the right heart cath, your pulmonary capillary wedge pressure, and they can go back and end up increasing your mean pulmonary artery pressure, causing pulmonary hypertension and eventually irreversible changes. So you can have mitral valve disease. You can have heart failure with preserved EF or preserved EF. All right. Next thing, I think this is the most common cause of pulmonary hypertension, is going to be type 3. So this is really secondary to any cause of hypoxia. All right. So what does hypoxia do? So when you have decreased oxygen, let's say decreased oxygen here in your lungs. So say someone has pulmonary disease. So pulmonary disease, this could be COPD, this could be ILD. Those patients are going to have decreased oxygen. And what does that decreased oxygen do? It causes pulmonary vasoconstriction. So the arteries that are going to these hypoxic areas of the lungs are going to be vasoconstricted. Now, this is a physiological phenomenon. The lung does not want oxygen. Does not want, blood to go to areas with poor oxygen, right? It wants to shunt bloods away from areas that are not undergoing good oxygen exchange and shunt that blood to areas that are. The problem you get to is when someone has really severe lung disease, they have hypoxia in all areas of their lungs, they have hypoxic vasoconstriction in all areas of the lungs, and eventually they get reversible vasoconstriction and then secondary get irreversible pulmonary hypertension. So COPD, ILD, really anything that's going to decrease lung hypoxia, or you also can have extrapulmonary causes. Most commonly, this is going to be obstructive sleep apnea, right? Decreased breathing at night, secondary to obstruction, usually in the larynx, with people that are big, have large necks, maybe they drink alcohol, take benzos. They're going to get hypoxia at night, and that's going to cause hypoxic vasoconstriction. Less likely would be something like a neuromuscular disease as well that can cause chronic hypoxia. So perfect, we just covered about 90% of pulmonary hypertension. A lot of times you can just look at an echocardiogram, look at the patient. Do they have COPD and they want 4 liters? Do they have heart failure with reduced EF? And they have a really, really low ejection fraction, huge left atrial dilation, and pulmonary hypertension. You can kind of say that the pulmonary hypertension is secondary to that. The next two are a little bit more rare, and you really need an index of suspicion to consider working these up. So the one that probably people get stuck on the most is going to be pulmonary arteriolar hypertension. So what is pulmonary arteriolar hypertension? This is going to be group 1. This is going to be group 1. These patients are actually going to have some reason that they're having pulmonary arteriolar vasoconstriction, right? So they're having some vasoconstriction or some damage to their pulmonary arteriolar endothelium, which is why it's called pulmonary arterial hypertension. So there really are a lot of different causes of this. Most commonly idiopathic. This is now likely been shown to be to genetic mutation of, I think, BMPR2, which is an embryological genetic mutation that leads to pulmonary hypertrophy. A lot of times, a younger patient, no heart disease, no lung disease, comes in with dyspnea on exertion, and then eventually gets a echocardiogram, right, heart cath that shows that the patient has high pulmonary arterial pressures, but does not have a high wedge pressure, and really doesn't have a reason of why they have high pulmonary arterial pressures as well. Next is going to be all your secondary causes as well. So a lot of secondary causes for this. One thing you have to work up is HIV. HIV can directly damage your pulmonary endothelium, leading to pulmonary hypertension. Another one that I've seen before, kind of the opposite of hepatopulmonary syndrome, which is secondary to increased nitric oxide, is portopulmonary hypertension. So what is portopulmonary hypertension? It's a patient with liver disease. They have liver disease. They have decreased clearance of endothelium, and that decreased clearance of endothelium by the liver ends up gets shunted to the lungs, and when it goes to the lungs, it causes vasoconstriction. Pretty poor prognostic sign if you do see this. Other ones, it's going to be meds. So meds, mostly meds. I think there's TKIs that could do this, like the statin, but it's a lot of times meds that cause vasoconstriction. Some meds could be like SSRIs. There's a question mark. It's kind of controversial ones that are called pulmonary hypertension. Other ones that may cause it are sympathomimetics, so things like amphetamines, methamphetamines, cocaine. These can all cause pulmonary hypertension from that arterial vasoconstriction. 5, autoimmune disease. So a lot of autoimmune diseases may cause this. You might get a question or might see a patient. And most commonly, I've seen it with this association. The patient comes into the outpatient clinic. The patient has, let's say, calcified nodules on their fingertips, Raynaud's phenomenon, esophageal dysmotility, thickened skin over their hands. Maybe if they have it systemically up to their arms, Matt-Tone ectasias. And the thing that I'm talking about is going to be CREST or systemic sclerosis. Both CREST and systemic sclerosis can cause this. So you might need further workup in these cases as well, especially if you have a high index of suspicion. Lastly, it's going to be congenital heart disease. So it's a little bit confusing. So, if someone has congenital heart disease, they're actually having blood flow, and usually it's going to start from the higher pressure side, from the left side to the right side. But over a long period of time, those patients are going to have increased blood flow through the pulmonary circulation, which is called shear stress, which is eventually going to lead, once again, to these irreversible changes in pulmonary arterial hypertension. So things like a VSD, severe ASD, these can all cause pulmonary hypertension secondary to congenital heart disease. I think I covered all the ones there. And lastly, we're going to talk about type 4 pulmonary hypertension. So which one is this? So type 4 is going to be chronic thromboembolic disease. So these patients should, in most cases, have had some sort of PE before. Basically, the PE goes to the lungs, pulmonary embolism goes to the lungs, and they get small pulmonary emboli stuck in your arterioles and over a long period of time, really distally in your arteriole as well, and over a long period of time. You have usually recurrent PEs and someone with either systemic hypercoagulability or something like May-Turner syndrome, which is an anatomical defect in which they get DVTs and subsequent PEs. They can get type 4 pulmonary hypertension, which is called chronic thromboembolic pulmonary hypertension. Last one, a little bit of a catch-all. Oh, one that I missed as well. In type 1, it's going to be schistosomiasis. So if someone has schistosomiasis, especially it's japonicum or Mansoni, they can have basically eggs embolized to their pulmonary circulation. Pulmonary arterioles get stuck there and cause pulmonary constriction and eventually pulmonary hypertension. Lastly, it reminded me because I think I used to read that schistosomiasis was in this category, but I think it's now in category 1. It's just going to be type 5. This can be multifactorial or kind of like unclear cause, and this is a few different ones. So some I've seen, some I haven't seen. Sarcoid, I have seen. So sarcoidosis, you can get pulmonary granulomas in your pulmonary arterioles. This can cause pulmonary hypertension. Another one in here would be sickle cell. Sickle cell, when they have hemolysis, it scavenges for that nitric oxide, and that decreased nitric oxide can cause pulmonary vasoconstriction over time. And lastly, one that I've seen a couple times is going to be ESRD. These patients can get pulmonary hypertension in a couple ways. And the ways that they can get it, some of them actually will have undiagnosed HFpEF. HFpEF is relatively more common in patients in ESRD as it shares risk factors. But they also have poor clearance of things like endothelin, which can cause vasoconstriction. As well, they can have increased flow from their AV fistulas. So that increased flow from the AV fistula will increase the preload on the right side, increasing the amount of blood flow to the lungs, causing shear stress and eventually pulmonary hypertension. So it's definitely multifactorial, but once or twice I've seen patients with ESRD, and one time we actually had to ligate the patient's fistula because we thought there was too much blood going from the systemic circulation to the venous circulation without going through the systemic arterioles, increasing right-sided blood flow, subsequently increasing shear stress in the lungs and causing pulmonary hypertension. So these are your major causes of pulmonary hypertension. But remember, you see pulmonary hypertension a lot, especially if you work my job as a hospitalist. 90% is going to be to these two causes alone. You have an index of suspicion for the others, but and consider them. But if you really have a patient where you expect them to have pulmonary hypertension from one of these causes, you may not have to do too much more work on. All right, next one, mixed up pulmonary question 37. All right, so this kind of gets a little bit to pulmonary hypertension workup, and I think I should probably go a little bit more into some of the manifestations of pulmonary hypertension. So one manifestation is going to be a split S2. These patients have high pressures in your lungs, right? So it takes a longer time for the RV to squeeze and the RV to get all of its blood out into that systemic circulation, which is going to make them have a pretty wide split S2. Remember, the pulmonic component, the pulmonary closure, should be after the aortic closure, but these patients have such even a harder time getting their blood out because of that pulmonary hypertension, because of that increased pressure in the lungs. It takes even longer. They have a wide and split S2. Other things is eventually these patients can start getting increased pressure of the RV, and when they have increased pressure of the RV and the RV is pumping very hard, you get RV heave. And lastly, once they start getting dilation of your right side of the heart, that can dilate your tricuspid valve, and tricuspid valve leaflets can come further apart, and you can get tricuspid regurgitation as well. Lastly, and actually pretty sensitive and specific sign is that closure of the pulmonic valve. Because there's so much back pressure coming from here, it can be pretty forceful, and you might feel palpable P2 palpable P2 by feeling the patient's pulmonic area. I just had a patient with physical diagnosis that had pulmonary hypertension and really had basically all his findings. He had severe tricuspid regurgitation from RV dilation. The patient had an RV heave from the right ventricle working harder, had a wide split S2, as well as having a palpable P2 that you could feel when you palpate over their P2 area for the cardiac physical exam. So that's some of the manifestations which you might see in your physical exam. Some of your symptoms might be worsening dyspnea, sometimes even chest pain because there's so much high pressure on the right side of the heart that they get a little bit of endocardial ischemia. And thirdly, they can get, because they're not getting enough preload from the right side to the left side, these patients can actually get pre-syncope and even syncopate, another thing that this patient that I was talking about had. So how do you diagnose this? And this kind of gets what this question is: what's your screening test to diagnose pulmonary hypertension? Well, it's actually going to be an echocardiogram. Most of these patients are going to have at least a little bit of tricuspid regurgitation. So on a formal, the way that you're going to diagnose it is really going to be from your tricuspid jet velocity. They're going to measure this with a formal echocardiogram to see if these patients have pulmonary hypertension. Based on the velocity, they can see what your pulmonary arterial, right ventricular and pulmonary arterial pressures are, but they assume that the right atrial pressure is normal, which means that a lot of times this may underestimate, right? Because a lot of these patients, especially if they start having RV failure, they may not have a normal RA pressure in that tricuspid jet velocity, which the calculation is based on normal RA pressure, may actually underestimate how much pulmonary hypertension that they have. Next, sometimes other signs that you can look for on a formal echo or things that you can see as well on a point of care ultrasound. It's going to be this. So if you're doing a point of care ultrasound, and here we're looking at your LV, right? Here's the marker. Left side is left side, so LV, LA, RV, and RA. So your LV pumps the systemic circulation, which should be larger than your RV, but in patients with pulmonary hypertension, that RV can become larger. So greater. Some things you look at for looking for signs of RV pressure overload is greater than 2/3 size, or 2/3 RV size to LV size. So if it's greater than 2/3 size of the LV, you think that there's probably some pressure overload. Other things that we can kind of see here as well is that, they have pretty good systolic function of your left ventricle, and one of the reasons why is they're probably getting decreased preload to the left ventricle. Left ventricle is increasing contractility. But here, not only is the RV overloaded, it's actually pretty dilated as well. Now, the other thing to think about is that it's hard to tell a lot of times if a patient has acute pulmonary hypertension, secondary something like a PE, submassive PA, or massive if they're hypertensive, versus do they have chronic pulmonary hypertension. So, definitely have to take patient presentation, history, and physical into effect when thinking, is it acute pulmonary hypertension or is it chronic? The other thing you might look at, and try to delete these a little bit, this is your short axis view. And what you're looking at here in your short axis view is, remember, RV is always in the front. So here's your RV, here's your LV. And another sign of pressure overload is the D sign. So you see this kind of looks like a D. This is a sign of increased RV pressure. What's going on here is that the RV pressure is higher than the LV pressure. So during systole, you actually see that bowing of the RV going into the LV as well, and that actually creates a, this should be circle, the LV should look like a donut, but here you can see that the LV looks like a D sign. It's because there's septal bowing from RV pressure pressing onto your LV. That's going to be called your D sign that you see in short axis view. Lastly, and I'll say this is a bit nuanced. And lastly, and this is going to get a little bit nuanced, is how do you know if it's acute versus chronic? If this wall here in the RV, the RV wall, is greater than 5 millimeters, it's likely chronic. Now, I say likely because, over a long period of time, it takes a long time for the RV to hypertrophy in response to increased systemic pulmonary circulations. But this is not, the end-all be-all. People with chronic pulmonary hypertension can still get a PE. So, it's not something to totally rest your hat on and say, oh, the RV wall is large, it's greater than 5 millimeters across, it's not a PE. Obviously, people with chronic pulmonary hypertension still get a PE. But this may help you. If you have a really high suspicion of chronic pulmonary hypertension and you see a RV wall that's greater than 5 millimeters, it probably means that the RV pressures have been high for a while. All right. That kind of went into formal echocardiogram and focus assessment of PA pressure, RV function, and remember your echocardiogram, that's what this question was on, is really going to be a screening test to diagnose pulmonary hypertension. All right, so do accept 19, question 78. Okay, so how do we work up pulmonary hypertension? All right, so like I said earlier, type 2 and type 3 is 90%, right? So, usually you can diagnose these type 2 and type 3. This gets a little bit more nuanced. You probably really won't get a question on this. But usually you can diagnose these with echocardiogram. But for type 2, right heart cath if left heart. Disease is does not account for all the does not account or disease is I would say expected. So if you have enough left heart disease to expect the pulmonary hypertension, an echocardiogram is enough. Same thing with the lung disease, right? So if the lung disease is enough lung disease to expect pulmonary hypertension, no right heart cath if enough. So if you have enough cardiopulmonary disease, say, okay, this patient has, let's say, HFrEF and EF is 10%, a huge left atrium, the patient has pulmonary hypertension, you probably expect that. You may not need a right heart cath unless you're doing it for other purposes, or say the patient has COPD on 4 liters of oxygen and they have pulmonary hypertension, you may not need to do further workup. If you think that the patient does have lung disease causing the pulmonary hypertension, other things that you can do is PFTs, especially if you think of obstructive disease, restricted disease, and probably in these cases you're going to want a CT scan as well to look for any interstitial lung disease. Extrapulmonary, and I would say for most cases there's so much co-occurrence with comorbidities, is looking for obstructive sleep apnea, doing polysomnography. So always reasonable really to do a polysomnography. Probably if you have a suspicion of obstructive sleep apnea, even if the patient has heart failure, even if the patient has lung disease, they can have co-occurrence of obstructive sleep apnea as well. So definitely reasonable to do that. If you do not think that the patient has enough cardiopulmonary disease to account for all of their pulmonary hypertension. That's when you start thinking about, okay, could this patient have type 1? Or if you have reasonable suspicion, could they have type 4 pulmonary hypertension? If you think that the patient has type 1 pulmonary arterial hypertension, you do need a right heart cath. And what are we really looking on right heart cath? There are a lot of things. Remember, mean pulmonary pressure greater than 20 is a diagnosis. So you're looking for that mean pulmonary pressure here of greater than equal to 20. All right. The second thing you're looking at really is you're going to do a pulmonary capillary wedge pressure. And what is a pulmonary capillary wedge pressure? Basically, you put a pressure sensor at the very end of the arterioles. You inflate a balloon around it, so you're only getting pressure from your left atrium. And if that pressure in the left atrium is high, you think that the patient's going to have type 2 pulmonary arterial hypertension. So this is a really good way to diagnose type 2 pulmonary hypertension, secondary left heart disease, if that left atrial pressure is high. For type 2, that there's ways that you can really calculate how much intrapulmonary resistance there are. One is Wood's units. So Wood's units greater than 2 is how much intrapulmonary resistance there is. If the Wood's units are greater than 2, you think that the patient does not have, you think there's at least a component of type 1, type 3, or type 4. Okay? So if that Wood's unit is greater than 2, you think there's definitely some sort of intrapulmonary pulmonary hypertension, which could be either type 1, type 3, or type 4. Or another way that you can do it is transpulmonary gradient. In transpulmonary gradient, it's a little bit easier for me to explain. So what a transpulmonary gradient is going to be your mean pulmonary pressure minus, so here, this pressure here, minus your pressure in your left atrium, which is going to be your stand-in is pulmonary capillary wedge pressure. For someone with a type 2 WHO pulmonary hypertension, that should be greater than 12. If they have some of the other causes, that is going to be greater than or equal to 12. So if you think there's intrapulmonary hypertension and intrapulmonary resistance, which means that there's Wood's units greater than 2, or there's a transpulmonary gradient, which is your mean pulmonary arterial pressure minus your pulmonary capillary wedge pressure, you're thinking that it comes from the lungs, and your differential diagnosis then goes to type 1, type 3, and type 4. Obviously, there's co-occurrence with like heart failure, obstructive sleep apnea, so people might have both. But if that transpulmonary gradient is greater than 12, the Wood's unit is greater than 2, you think there is some intrapulmonary hypertension, not totally accounted for by your left atrial pressure. So your differential diagnosis says, okay, there's some type 1, type 3, or type 4 going on. So really for type 1, you're going to need a right heart cath to diagnose. And once you're considering this, type 1, there's other work that you can do. So obviously for meds, check a med list, right? Absolutely. Maybe really ask the patient if they use a list of drugs. You might have to check an UV acid or a drug screen, connective tissue, check an ANA, screen for crest, scleroderma. So think about if they centromeres, think about a SCL70. For portal pulmonary hypertension, you have the suspicion that they have signs and symptoms of, everyone should really get LFTs, signs and symptoms of liver disease. You should probably check a right upper quadrant if you're in the hospital, ultrasound look for liver disease, congenital heart disease. The way that you're going to diagnose this is a bubble study. So those bubbles will go into the right side, and if there's a hole, let's say through VSD, you'll see quick bubbles over to the left side. Even if the pressure is on the right side or low on the left, you'll still see some bubbles. If the patient has a significant travel history, for schistosomiasis, you might check a OP, lobe parasites, and lastly, genetic, if you're considering genetic cause. You check those genes for that genetic mutation. You mentioned that BNPR2. Don't quote me on this. I think it's BNPR2. I forget the exact genetic association. All right, so just remember, if your pulmonary hypertension you think is not totally accounted for by type 2, type 3, or we'll get into as well as type 4, you really want to do a right heart cath to help you diagnose type 1, though any cause of intrapulmonary pulmonary hypertension, which is type 1, type 3, or type 4, will have intrapulmonary increased pressures. So they'll have Wood unit greater than 2, and they'll have that transpulmonary gradient, which is your mean pulmonary artery pressure minus your life pressure greater than 12, meaning that pulmonary hypertension that you're finding is not just due to left-sided heart disease. All right, so it's going to be helpful. All right, do MCEP 19, question 10. All right, so we kind of went through a little bit already of the pulmonary hypertension workup. If you have a suspicion for it, and you think that the patient has type 4 pulmonary hypertension, which means that they have a clot's moved, and you've had showering and more of your distal pulmonary arterioles causing pulmonary arterial hypertension, you're going to want to work this up. And the workup you're going to do is going to be a BQ scan. All right. Sometimes people think, oh, let's do a CT angiogram, but the CT angiogram is not really going to be able to see these tiny microemboli in the lungs, so it's not actually going to be super sensitive. So BQ scan and looking for decreased perfusion in these areas is going to be much more sensitive for diagnosed type 4 pulmonary hypertension. So that would be your next step if you have a clinical suspicion for this. All right, then that would be kind of all our workup for pulmonary hypertension, and kind of like the steps. First is, really you're thinking, is it type 2 or type 3? If you have a suspicion for type 4, take a BQ scan. You have suspicion for type 1. Your next step is really going to be a right heart cath as well. Not only is the right heart cath going to help you diagnose type 1 pulmonary arterial hypertension, and say make less likely something like HFpEF, it's also going to help your management, which we'll get to in the next one. Type 5 pulmonary hypertension, check for these if there's any suspicion. Right. Hopefully, patients will already be diagnosed with things like sickle cell, things like ESRD. If you see CT findings with, bronchovascular nodules, hyaline-lymphadenopathy might work up for sarcoidosis. But work those up if you have suspicion. All right. Do MCEP 19, question 46. All right. So this one, I think this may be our last question, gets into pulmonary hypertensive management. So let's do type 3 and type 2 and type 3 already. So let's go through type 2 pulmonary hypertension. So what is going to be our management? Really guideline directed medical therapy if the patient has heart failure. HFrEF has some more treatment really than HFpEF. But guideline directed medical treatment. These patients may need diuresis that can help lower a lot of times their left atrial pressures. And then if they have valvular disease, so if they have mitral stenosis, mitral regurgitation, significant pulmonary hypertension is usually an indication for one of those diseases for actually fixing the valve. So they may actually need valve surgery, replacement, and repair, depending if it's mitral stenosis or mitral regurg. Type 3 pulmonary hypertension, obviously you're going to try to fix the underlying cause, but chronic pulmonary hypertension may be kind of difficult to really treat that totally. But just remember that these patients need oxygen. So you'll give them oxygen if their ambulatory pulse ox is less than 88%, or, and this is missed sometimes in patient, less than or equal to 89% if RV failure. So you can be a little bit more aggressive with the oxygen therapy if you do see signs and symptoms of a right ventricular failure. So it's not always less than or equal to 88%. Sometimes it can be 89% if you see signs of RV failure, something to remember. Next is going to be type 4 pulmonary hypertension. So how do we treat that? So first line, it's going to be surgery. Now, sometimes patients can't undergo surgery. Maybe surgery doesn't decrease the pressures all the way. And in those cases, second line would be things like pulmonary angioplasty, or a new FDA-approved medicine is Riociguat, which is a cyclic GMP therapy agonist, which is going to cause arterial vasodilation. So maybe it'll help get the blood flow a little bit around the small pulmonary and wide lungs. All right, so type 5, it kind of depends on what it is. And lastly, probably the hardest is going to be how do you treat type 1 pulmonary arterial hypertension. So I talked before, you need a right heart cath, and what you kind of do in a right heart cath is you're going to measure your mean PA pressure. These patients, you're going to have them inhale nitric oxide. So they're going to inhale nitric oxide, and you're going to see if that nitric oxide is causing vasodilation. If that nitric oxide is causing vasodilation, and that will, if it is causing vasodilation, your mean pulmonary pressure will decrease by 10. Then these patients are vasoreactive, and you can do a calcium channel blocker. So that would be first line. Not everyone's going to be responsive to a calcium channel blocker. And even people who are responsive may become unresponsive over a period of time, but this is still our first go-to. If the patients are not vasoreactive, so not vasoreactive, I'll just put VR here, then it kind of depends on how symptomatic the patient is. If asymptomatic, which is group class 1, so this is going to be class 1, you'll do a monotherapy of an oral. So we'll do a monotherapy of an oral. Your choices here are going to be ambrisentan, which is a endothelin antagonist. So ambrisentan, which is an endothelin antagonist, tadalafil, which is going to cause phosphodiesterase inhibition, causes arterial vasodilation by that, or riociguat, which we already kind of talked about, which is cyclic GMP stimulator, and that's going to cause arterial vasodilation. If they are class 2 to 3, so these patients have symptoms, so which is symptoms with exercise. The newish trial is called the Ambition trial, and usually you'll do dual therapy. And the dual therapy you're usually going to do is going to be tadalafil. This is what they did in the Ambition trial plus ambrisentan. It's shown that dual therapy is greater than 1. Class 4, this gets really bad. I had one patient in the ICU with this when I was in residency. These patients are symptomatic at rest. So this is pretty dangerous, and these patients are going to need IV therapy. Usually going to be IV prostacyclins like epoprostenol, which is going to cause arterial vasodilation. But at this point, too, you'll put them on IV therapy. You'll try to decrease your pulmonary artery pressures by this and decrease their symptoms. But these patients probably need to be evaluated for cardiopulmonary transplant at this point. So that's going to be your treatment. So type 1, and they're vasoreactive, and so they have vasodilation. You're going to use a calcium channel blocker. If they're not vasoreactive, depends on what class they are. If they're asymptomatic and they're class 1, they'll use monotherapy. This is based on what UpToDate says, not exactly mixed-up. And ambrisentan did out for the riociguat. If they're class 2, which means they're symptomatic exercise, you'll do dual therapy, usually ambrisentan and tadalafil together once you get to this point. And then if they are class 4, which is symptoms of rest, they need to be hospitalized and need to be put on usually an IV prostacyclin, like something like epoprostenol, as well to really decrease those mean pulmonary artery pressures. And at this point, they would need to be evaluated for a cardiopulmonary transplant as well. And the reason why it's cardiopulmonary, the arterial vasoconstriction, at this point, this is going to be reversible. So they're going to need new lungs, and at this point, this patient may also need a new heart as well, especially if they have significant RV failure and RV dysfunction, which they probably will if they're having symptoms at rest. Lastly, type 5 kind of depends on the cause. So treat cause. Like I said, I did have that one patient with ESID, and we actually had to ligate their AV fistula to slow down the arterial venous shunting to decrease the blood flow to the right side as well. Sarcoid, you'll probably do treatment with sarcoidosis as well, which could be steroids. If refractory, you got the Trexate, TNF-alphas, things like that. Sickle cell, I don't really think has a great treatment, unfortunately. So that's management. And I think for this one, do this question, except 19, pulmonary question 101. But my mistake, we already answered it. For this patient needs a surgery because the patient has CTEPH, and the surgery that you're going to do is going to be mechanical thrombectomy. So you're actually going to go in, remove this thrombus. They really need to go to really highly specialist pulmonary hypertension surgeon. The patients who've done more, the surgeons who've done more surgical thrombectomies are going to be the surgeons who will have the best outcomes. So go to a surgeon for a surgical thrombectomy for type 4 pulmonary hypertension that can do it. And you can actually, lastly enough, and why it's so important to diagnose type 4 pulmonary hypertension, and you should really do a VQ scan. One, if they have a right heart cath with high Woods units, high intrapulmonary resistance, high transpulmonary gradient, if you have a suspicion for it, or if you have what you think is type 2 pulmonary hypertension or type 3 pulmonary hypertension, but you don't think that their cardiopulmonary disease accounts for all their pulmonary hypertension. All right, relatively quick one, but review is, well, I'll just put the slides here for you at the end. This is going to be the causes of pulmonary hypertension. Really best to think this about anatomically, with type 1 pulmonary arterial hypertension coming from the pulmonary arterioles, type 2 coming from left heart disease, type 3 coming from chronic hypoxia, type 4 coming from chronic thromboembolic disease, and type 5 pulmonary hypertension. I put it type 4 here. That's a typo. Type 5. Type 5 pulmonary hypertension being that kind of unclear or multifactorial cause, which includes sickle cell sarcoid, heme malignancies, and ESRD. Here's going to be your workup. So if you have enough type 2 and type 3, remember this is 90%. You're going to see a lot of pulmonary hypertension in hospital. A lot of times you don't have to do too much more than treat the underlying disease. If you think that they have enough, a sufficient amount of left-sided left-sided heart disease or chronic hypoxic lung disease, for these patients you might not have to do too much more. Though I would say, if you do a stop bang, or if you think that there's a reasonable suspicion for obstructive sleep apnea, you should check a polysomnography. Same maybe with type 4. You might be, if you really have a high suspicion of type 4, you might just be able to get with a VQ scan. That's controversial. But if you're really trying to make that diagnosis of type 1, you really are going to need to do a right heart cath. Right heart cath as well is going to actually be your gold standard for your mean pulmonary pressures. As noted earlier, echocardiogram actually underestimates them as well. So remember, a right heart cath could be in their future, really, if you don't think they have sufficient cardiopulmonary disease to account for the pulmonary hypertension. Lastly is management. If these are active calcium channel blocker, if not, depends on what class they are. They're asymptomatic, it's usually monotherapy, 2 to 3 combo treatment. Class 4, treat with IV therapy. Type 2 pulmonary hypertension, really treat, guideline-directed therapy for the heart failure. If you think it's either mitral disease, it's probably going to need surgery. Type 3, treat the underlying cause, but obviously try to give them enough oxygen to reduce that hypoxic vasoconstriction. At type 4, they're going to need a pulmonary thromboendarterectomy. As noted earlier, so pulmonary thromboendarterectomy is going to be surgery. If operable, think about pulmonary angioplasty or CGWAT. At type 5, kind of treat depending on the cause. And that is it. Thank you, everybody.